Can we please call the next speaker? Dr. P.A. Mahesh, who is an Associate Professor, Department of Pulmonary Medicine in JSS Medical College, Mysore. He passed MBBS in 1992 from KMC, Mangalore. He has a diploma in TB and chest diseases from Trivandrum Medical College. He is also a holder of Diplomate of National Board from Trivandrum Medical College. He is active in undergraduate medical, dental and postgraduate teaching. He is currently the Associate Professor in JSS Medical College. He has multiple Indian and international memberships, associations, and is also on national reviewing committees.
Thank you, Chairperson, for the kind introduction. At the outset, I would like to thank Chandrasekhar for having given me a chance to be here and spend time with you. This is my third visit here, and I can see that it's going from strength to strength. And I think this is one of the longest titles that I have spoken to, which Chandrasekhar gave me. Usually the titles are very short, and he wanted me to speak on the treatment of allergy is not only symptomatic, but actually a lot more can be afforded. So I am going to deal with it more in a clinical way, and then spend some time on the sublingual kind of immunotherapy, which is probably something that is very, very useful for these patients. So the brief outline would be the key points that we should take in the history, the limitations we have in the clinical examination. Mainly I will be concentrating in the lab to look at the spirometry as well as allergy testing. We can look at the list of the other tests that could be done in these patients. Preparing an individual management plan for these patients to look at both the drugs as well as the devices. I will not be spending a lot of time on that because of the lack of time. Patient counseling for the management. Again, this topic itself would take an hour or so. So I would probably be just mentioning a couple of points which are key, and then spend some time on the sublingual so-called immunotherapy or SLIT. Now, when we have these patients, either they come with rhinitis or they come with asthma, or generally they come with both. Almost 80% of the patients with asthma would have had preceding allergic rhinitis. Patients who have had allergic rhinitis, if they don't have asthma yet, 50% of them will do so in their lifetime. And in the studies that we have done, we have realized that the highest risk is in the first 2 years, and then the risk remains for the next 10 years. So if you find a patient who has got rhinitis for the last 15 years, the chance of him developing asthma is remote. But if there is a patient with rhinitis for only 6 months or 1 year, which is not a time when we usually see them because they see their family practitioners or the ENT people, then the risk of developing asthma is very high. The risk increases 3 to 4 times if there is a family history of asthma, and the risk even further increases if this subject on allergy testing is found to be sensitive to the dust mites, both in adults and children. If they are sensitive to tree pollens, if they are adults, then you find that this patient developing risk of asthma becomes very, very high. So it's not just the subject that we are seeing that they have some common cold. Any patient who has cold without fever definitely needs to be aggressively treated and managed, because to prevent further complications like asthma. As far as the treatment is concerned, again we find these patients going on taking only symptomatic treatment with antihistamines. It is key that you try to use the ARIA classification, which is very simple. You can look at whether the patient is a blocker or a runner. If there is a blocker, he has more of nasal obstruction or he has more of rhinorrhea. If he has nasal obstruction, he has inflammation, which means he needs inhaled nasal steroids. Giving only cetirizine is not going to help him because antihistamines have absolutely no or very minimal anti-inflammatory activity. If he is a runner, then of course he can be benefited with antihistamines symptomatically. Alone may be sufficient if his duration of symptoms is less than 1 month. If it is more than 1 month, he will definitely need nasal inhaled corticosteroids. Of course, there are patients who have both as well. And as I said earlier, the key point is to see or to understand that the rhinitis precedes asthma in almost 80% of the asthmatics. The first 10 years is crucial, the first 2 years more so, because 80% of the people who are going to develop asthma will do so within the first 2 years. And there are two main studies which I have looked at, called the Prevention of Asthma Study, PAT study, and the last Jacobson study, which can show that you can prevent asthma if they are properly managed. So that is key. And again, when we take a history, most of the guidelines that are present at this point of time do not mention this. What they tell you with the, like for example, the GINA severity or the ARIA severity tells you the severity of the disease at this point of time that the doctor sees the patient. What is even more critical is to see what is the time taken for the patient to move across different grades. I think that is not being dealt with any of the guidelines at this point of time, because the progression of the disease is important. How aggressively you have to manage these patients depends on the progressive of the disease. Like for example, a patient will move with asthma from GINA 1 to 4 in 10 years time, and the next patient will move in 1 year's time. Those two cannot be the same. Those two are entirely different and will need to be managed differently, and these are not addressed with the present guidelines. And to assess the progression of disease is not a very difficult task. All it takes is to ask 4 questions. What is happening in the frequency of symptoms in the first year of the disease? What is happening now? And you will find that more than 80% of the patients will tell you, if you simply ask this question, that it is now more frequent. It is now lasting longer. What used to simply resolve within a day now lasts longer. It is more severe now. Work and sleep is being now affected, which it was not affected in the first year. They need more and more medicines, which is to resolve with one nebulizer. Now even after 4 or 5 days of daily 3-4 nebulizers, still not resolving. So all it does is you have to give a very simple or ask very simple questions, and this will tell you whether the disease is progressive. The rate is something which is individual, and this rate will probably decide or help you how aggressively you have to manage these patients. Lot of patients or even the referrals which we see that are so called resistant asthmatics, difficult to treatment asthmatics, actually are not difficult at all. I should say 90% of them are really not difficult. All you have to do is again take a good history and you will have the answer to the problem. If you see what were the medications the patient was using, whether they were using a reliever, preventer or both, most of them will be only on symptomatic treatment, and this is no good. It will not help to control the inflammation, nor will it help to halt the progression of the disease. What was the dosage of the medications? Patient is on inhaled corticoid appropriate, which is not appropriate to the severity of the disease. They are taking, like for example, something like an Aerocort, which is no good if he is in GINA 4. He will need far higher dose of inhaled steroids than 50 to 100 microgram of beclomethasone. So once that is addressed, he is no longer difficult to control asthmatic. Regularity of usage. They will show you the appropriate dosage of the medicine, but if you ask them, are you using it every day? They will tell you, no, I only use it when I have a problem. So if you take care of that and if you counsel them, it is not difficult to control asthma at all. Medication technique, we have had patients swallow rotacaps. We have had patients who use an inhaler where everything goes out into the air as if they are smoking, and absolutely nothing goes in. And even with the best techniques with an MDI, only 10% of the inhaled medicines is going to reach the lungs. If the technique is poor, then absolutely nothing reaches, and therefore even though the dosage, everything is appropriate, it's not working. And of course the compliance of these patients. It is also important that you take a history of the concomitant diseases, whether the patient has other comorbidities which can affect, because these also, like for example, a cardiac disease can cause dyspnea, and you need to be aware of this, especially in elderly patients. Patient on beta blockers, you go on giving them beta agonists, may not find good relief because they are already taking beta blockers. All it takes is a history to find out that they are using beta blockers. And of course, they will also be using certain drugs like aspirin, especially the elderly subjects. There is an entirely new chapter in most of the asthma textbooks called as aspirin sensitive asthma. Again, all you have to do is ask history. What are the drugs you are taking? Can you just show if the patient is not able to name them? And if you find the patient is on aspirin and he is not responding to your oral corticoids, you know what is the reason. All you have to do is probably substitute aspirin and you will find that the patient is very easily managed. Sometimes we have found that with ACE inhibitors as well. So coming to the clinical evaluation, why do we have to do some of these tests that we do? The basic problem, though you can make an assessment of an airway obstruction in many cases, because you can have airway obstruction without rhonchi as well, but when the rhonchi is present, you can be sure that there is an airway obstruction. But unfortunately, it doesn't tell us how severe is the disease. It could be very severe. We find crepitations more than rhonchi, doesn't mean they have bronchiectasis, it can still be asthma. Of course, it will help you to rule out other differential diagnoses. You will have to do a careful clinical evaluation. Sometimes very severe asthma, and in some patients, it can happen in very few years, 3-4 years of asthma, they are already into airway remodeling. And these are the patients that we need to work up very aggressively to halt the progression of the disease. And once that happens, unfortunately, there is no reversal, and they behave typically like a COPD with the reduction in the lifespan and all that. The two tests which are very, very useful, which every patient with asthma or even rhinitis, for example, because you can have a lot of patients with rhinitis with subclinical asthma. One is spirometry. Again, it is important. We realize that most patients don't do. Even if you are family practitioners, I mean most physicians don't adopt, but even if you are a family practitioner, you can at least use a peak flow, which is useful. You generally don't treat patients with hypertension without measuring their blood pressure. How can you treat this patient without seeing how severe the disease is? How can you decide on what dose you have to use? But when spirometries are done, which is rare, we find that spirometry doesn't meet the ATS criteria. There are specific guidelines, and only when spirometries meet these criteria, the results are valid. Unlike a blood test, this is dependent wholly on the patient, and if the patient doesn't do it properly, unfortunately, then this test has no value. The second most important test is the allergy testing. It is important for us to realize that you need to do a standardized extract needs to be used. You can assess it either by doing a skin prick test, or you can do it by doing a specific IgA as well. Specific IgA, of course, is much more expensive. Now, what is the need for this allergy testing? Why do we have to do it at all? Now, again, we have seen that a lot of family practitioners diagnose allergy by looking at an absolute eosinophil count, which actually is of little value. Because if you want to take patients with allergy and asthma, if you take 100 patients, only 30% would have an elevated eosinophil count. And when it is elevated, it can often be due to other reasons. Therefore, if you want to look at an eosinophilia to diagnose allergy, that is the last test you should be doing. We only do it to rule out when the AEC is more than 2000, to rule out other diseases that mimic asthma. That's the only reason we look at AEC. Otherwise, it has absolutely no role if you want to diagnose allergy of any kind. Now, the total serum Ig also we have seen people use it. Again, it is of not much value, though it is increased in about 60% of the patients. But a lot of patients with allergy and asthma can have normal serum Ig total. And even in patients when it is elevated, sometimes it can be due to other reasons as well, though not as often as the AEC. So, the skin testing or a specific IgE measurement, even if you want to do, probably if you do 3 or 4, like for example, you will be able to pick up 90% of the patients. For example, you can do dust mite, you can do cockroach, you can do Parthenium and prosopis. Almost 90% of the patients that you see in regular practice, if you want to diagnose whether they have allergy or not, you do just 4 and that's fine. Only 10% of the patients you will miss. So, you can simply do very minimal if cost is a factor, and you can still diagnose most of the cases. If you want to help the patient to do an allergy avoidance, which is useful because there is a concept called as allergy threshold. What does this mean? is the number of particles that is required to initiate an allergic response. A patient is sensitive to dust mite, one patient will need 50 and he is sensitive throughout, he is symptomatic throughout the year. Another patient will need 50,000, he is only symptomatic in the month of December when he is using a blanket. So there is this concept of allergy threshold. Though they are allergic to the same substance, their symptoms will vary depending upon what is their so-called allergy threshold, or if you want to call it allergy resistance. And in subjects who have higher allergy thresholds, you control the inflammation with the drugs for 6 months, 30% of the patients can be able to avoid medicines only by practicing the allergy avoidance. Now, if you simply ask the patient to avoid dust, it is almost impossible. The people will be cleaning the house every day for so many years, and if you want to tell them to avoid dust, it is absolutely impossible. But if you find out what is the offending allergen, you will be able to reduce the concentration of the allergen in the dust. The quantity of dust may remain the same, but the concentration of the allergen can be reduced. This is what is going to help the patient. And to do that, you need to know the source. Otherwise, if you give them the whole list at 24 hours a day, is not sufficient to do that. So that's why you need to give very targeted counseling. Spirometry, of course, it helps us to confirm the diagnosis of asthma when it shows that it is reversible. Second, we see a patient with lung function of 20%, you give the medicines, he is back to 80% or more, you know that there is no airway remodeling in this patient. Again, it will help you. If the patient does not show a reversibility on spirometry testing, need not brand him as a COPD or that he has had airway remodeling, you can use steroids and for about 14 days oral steroids, and then you can repeat spirometry before you say that it is a fixed airway obstruction. We have seen even patients like, for example, even if they have normal PFTs, when we see them for the first time, we still do a bronchodilate reversibility because though we say 80%, there are patients who will have a FEV1 of 120, 130%. For them, even 80% is grossly abnormal. So even if you see a normal PFT at pre-bronchodilator, but if you are clinically you suspect that he has asthma, you please do a post-bronchodilator and you may find that his lung function has now improved to 120, 130. It's not an uncommon at all. So in patients like, for example, when you have clinical history, but you do a PFT pre-post, it is normal. Don't still brand them as normal, because in early or stage 1 or so-called intermittent disease, it is only abnormal at 2 o'clock in the night when he has a wheeze or cough, when you are not doing the spirometry. At that point of time, you can give them a peak flow meter at home. They can do it at the point of time when they have a problem, and then you can diagnose. And this is also useful if you are looking at an occupational trigger. As we again discussed earlier, if you do the allergy testing, it confirms atopy. It helps the patient to know that this is the kind of reaction occurring in the nose and lungs, helps to identify the source of the allergen, whether it's indoor or outdoor, can help roughly to give you the severity of the patient's allergy, helps to plan for the allergy avoidance, helps for you to select the antigens for immunotherapy. Now, what about the other tests that may be useful? None of these are generally very useful for the diagnosis of allergy. Mainly they are used to rule out other conditions. You want to do an X-ray chest or an X-ray sinus, for example, mainly to rule out other conditions. CT chest, if you want to suspect bronchiectasis, probably a CT chest will be useful, especially when you find that the patient is a difficult to control asthmatic. You do HRCT and find that he has mild bronchiectasis. That's the reason he is not easy to control, and that's the diagnosis. Sometimes you may have to do bronchoscopy. Very rarely we have seen patients with lung cancer present as difficult to control asthma. Bronchoscopy there is useful. Nasal smear for eosinophilia. Sometimes we have patients with rhinitis. You don't know whether it's allergic or non-allergic. You can simply ask the patient to blow in the slide, and if you find eosinophils more than 5%, you can be sure, almost sure, because there's a rare condition called as Neris syndrome or non-allergic rhinitis with eosinophilia syndrome as well. But mostly in your clinical practice, when you find patients with rhinorrhea, and if you can demonstrate eosinophils there, it's a fairly simple test for you to suspect that the patient has got atopy. Of course, in India, you must always rule out tuberculosis. Don't forget that. AEC, as I said earlier, is mainly to rule out eosinophilic lung diseases. Total serum IgE is normal again if you suspect vasomotor rhinitis in some of these patients. Now, preparing an individual management plan first rests on what drugs are you going to choose, again for the lack of time, because each of them itself, for the rhinitis itself is 30 minutes, asthma itself would be 30 minutes, so I will not be able to spend time on that. But basically these are all the list of drugs that we have that are useful in managing rhinitis. Again, these are the drugs we have that are useful in managing asthma. Each one may have to be adjusted individually for each patient to get the best or the optimum benefit. Time is to choose the device for each patient, which is probably more difficult. But if you can do a spirometry for an adult, if it is more than 1 liter of FEV1, then they can use any device that they choose. Then we generally give the choice to the patient. You choose what you want to use, you can use it. But if the FEV1 is less than 1 liter per second, then there is no way this patient can use a dry powder inhaler, because they will not be able to generate sufficient inspiratory flow rates for this powder to reach the lung. So if it is more than 1 liter, any device is okay for an adult. If it is less than 1 liter, always use a MDI with the spacer. Avoid using a dry powder inhaler. Or if you can simply see that the patient is very sick, his peak flow is less than 100, 150, please don't give him a dry powder inhaler, because it is not likely to be effective. Meter dose spacer with spacer can be used with anybody. Even in children just born, with the baby mask you will be able to use it. Meter dose without spacer I generally don't recommend, because in the studies that we have done, one group with 15 days training, intensive training, half an hour by a clinical pharmacist, over a period of 2 months, we found that only about 60% of the patients got the technique correct. 2 months further follow-up without any guidance showed that 60% came down to 20%. So if you just tell them once, maybe only 10% of them will be using it correctly. So we want to use an MDI, always use a spacer so that you don't have problem with the headaches. Nebulizer in patients who are very sick, who are unable to coordinate, or if they have very severe airway obstruction, then because the jet is coming under pressure, you will be able to reach the smaller airways. The problem with the dry powder or the MDI with very severe obstruction, if you don't want to use oral sometimes, oral or parenteral would be a better choice for the first week to add on to your regular treatment, because the drug may not reach the small airways and the patient will continue to be symptomatic. Nebulized medicines will help in such a regard. Now for the pharmacotherapy there are key areas. Again, the next 3 slides itself can take 3 hours if you really want to go into the details. I am just going to tell you few key messages that you will have to give to the patient. One, the need for prolonged duration of treatment has to be counseled. It's how you counsel to the patient. The same drugs are available in the market. Why some doctors do better than others is because they are able to counsel better. That's key. That's key to the success of your treatment. Need for regular medications, need for inhaled medications, need for inhaled steroids. Why they should choose steroids? Safety of inhaled steroids may have to be discussed with the patients, and always teach and check device use and technique, especially if the patient is not responding to your treatment. That will take care of almost 50% of your difficult to control patients, because they are not using it appropriately. Again, need for the consistent, it's not that they do it once a week or they do it for the first month and then get away with it. That's not going to help. It has to be consistent, it has to be prolonged, probably lifelong in many of these patients. It's important not to just give them a list, but try to identify measures individually that can be integrated into the patient's lifestyle. That's key. Identify the time and people to do it. You can give them a list, but he has nobody in the house to do it. There is no way he can do that. Of course, then you can also discuss barrier methods. This is something, especially the SLIT part of it, which will take the next 10 minutes. I'll try to finish as quickly as possible. Now, the first thing to look at immunotherapy as an injection is nearly 100 years. 1911 was the first time when Noon started, and then they were different. They were local, nasal, but the one that is standing now is the sublingual immunotherapy, which is what I will be looking at. Now, the problem with subcutaneous route, it has a lot of severe side effects. Many deaths have been reported because doctors have not been appropriately trained as to what to use, how much to use, also to handle an anaphylactic reaction. So, some countries like UK for almost 3 decades did not use it at all. So, now there are safer routes, which is the sublingual. Local nasal also has been used, but of course the sublingual one, now with a lot of trials, almost 50% of the subjects in Europe are using sublingual immunotherapy, and probably approved by the WHO for home use. Normally it has to be taken in the hospital, but for the SLIT it can be used in the home as well. Now it is now accepted by the WHO as a valid alternative to the subcutaneous route. Again, there were two things, but the sublingual swallow, wherein the vaccine is kept under the tongue for 1 to 2 minutes and swallowed, which is the one that is at present recommended. What is used here is the same antigens to which the patient is allergic to, and this is also so called as allergy vaccine in many of these. Now still, though it has been in use for the last 25 years, still there is a lot of work needs to be done. One, the dosing itself, the optimal dosing is not yet established. Different studies have used different doses, sometimes up to 500 the dose of injections, but only high dose SLIT is effective. Very low doses are not effective. At least more than 50% of the dose required for injections need to be used. As the dose increases, the efficacy also improves, but the side effects also increase. So that is a trade-off which you have to do, and the average annual dose has to be calculated, and that is daily dose is better, which has to be divided and used. Now, is it useful? There are so far about 47 double-blind placebo-controlled or randomized controlled studies which have demonstrated improvement in symptom scores, reduction in the medication scores. It is useful for rhinitis, asthma as well as conjunctivitis, and the improvement were noted in some subjects at the end of 1 year, some subjects at the end of 2 years, and some at the end of 3 years. 35% of the trials also did not show any benefit, probably because the dosage, the standardization of the extract, the duration, the schedule. So further research is needed to standardize all this. So what were some of the key points is the progression of sensitization was halted in one of the study. Progression to asthma was reduced in the same study. It also reduced the new allergy development, and the improvement in this study was seen from the second year onwards. One more study showed that again there was a reduction in the development of asthma, and the effect persisted even after discontinuation of the sublingual immunotherapy for 5 years for the next 5 years. So it is something that is going to be persistent as well. Now what are the mechanisms? It acts at various levels. Again, because of the paucity of time, not going to go into the details, but it can act on mast cells, it can act on basophils, it can act on the T cells, especially the Treg cells, and change the balance. It can act on the eosinophils, it can act on the specific IgE and increase in the specific IgG4, and the different time taken for each of these changes to occur. Now of course the Treg cell is the one that is key as far as allergy is concerned. We were talking of Th1 and Th2, now we have the Treg cells also in play which can control, and Treg cells are also affected when we are talking of the sublingual immunotherapy, and that's probably one of the reasons. Even if you use it for example one antigen, it is also useful against other allergens because the action on the Treg cell is global, it is not only specific. So as I said, the Treg cells are critical, and the IL-10 and the TGF beta help in suppressing the IgE production and stimulating the IgG, especially IgG4. So the mechanisms of action is similar to that as seen with the subcutaneous, and the antigens that are put on the tongue are shown in the oral mucosa even 20 hours after the administration. Though they keep it only for 2 minutes and swallow, they are there taken up by the local antigen presenting cells even up to 24 hours in the oral mucosa. It has been demonstrated. More studies of course needs to be done. Now the most critical point here is, unlike in the subcutaneous injections, there are no death or very severe reactions, and that's key. There are hardly any studies that have looked at the subcutaneous as well as the sublingual immunotherapy, but we find that they are almost similar. Again, for the paucity of time I am not going to go into the details, Just to compare between these two, home administration subcutaneous never, SLIT is always, root is of course oral. Discomfort because it is used with glycerin and sweet to taste, rarely you will have any discomfort except the danger that the children may swallow more of it because it is sweet. Safety is absolutely, it is safe. Deaths never reported. Adherence, they find it better because they don't have to go and spend an hour in the doctor's clinic twice a week. Dosage is 3 to 375 times higher dose is generally used, at least greater than 50. Cost, direct cost is higher because you are using more antigens, but the indirect cost, traveling, loss of work, staying in the clinic is far lower. Patient acceptance is higher. Efficacy is some of the things, there are only 1 or 2 studies, like for example prevention of asthma. You need a lot more studies, and maybe which are ongoing, maybe in the next 5 years they should be there. There are also other data that SLIT can prevent the new sensitizations. Effect, again they are long lasting, but as I said earlier, we need more data. Switching from back to TH1 from TH2 is proved in subcutaneous. Studies are ongoing. Recent studies have shown same effect, and it is likely to happen. So the sublingual immunotherapy represents a significant advance in allergen specific immunotherapy, especially because of the safety. Cochrane analysis had shown that is useful both for adults and children, both for rhinitis and asthma specifically, and the triad of pharmacotherapy and the allergen avoidance and immunotherapy will give the maximum benefit to these patients. Now, just a couple of points which I want to highlight. Over the last decade or so, at 3 time points, about 2,500 children we have surveyed in Mysore, and we find that there is almost a 50% increase in the prevalence of rhinitis and asthma as well. So, as specialists in the field, it is something that concerns us, because then where do we stop? There are countries like New Zealand that has 40-45% of children with asthma, and is there a role, like for example, sublingual immunotherapy to be introduced earlier? There is what is called as an allergy march, starting from the exposure to the allergens, to the development of skin allergy first, and then of course comes the food allergy, then the nasal allergy, and then asthma. Which point of time, whether we can find out who are the patient at risk and try to intervene early to halten the progression of the disease, or maybe even to prevent asthma, that is some of the key. Thank you very much. Yeah, please. Yes. Generally we test about 35. That should be sufficient. If you know the local aerobiology, you don't have to test 150, 200 allergens.
So you find out the allergen.
Exactly.
And you get the antigen antibodies for that one.
Sure.
Sensitizing.
Yes.
Suppose you use it.
Yes.
Suppose he may become allergic to other.
That's what I showed you. There are studies that have shown that these prevent the sensitization of new allergies, 1. Second, the action on the TH1 cells, on the Treg cells is global. It's like a switch.
So again,
you switch off the allergy switch.
Again, we have to switch on to other immunosuppressants.
No need. That's what I'm trying to tell you.
For one allergen, he is
patient has got 10 allergies. You are giving only for 1. Patient will respond to all 10.
I see.
Exactly.
That happens.
Exactly. Yes.
Okay.
Yes, exactly.
What is the role of
sodium chromoglycate
versus local cortisone nasal for nasal allergy?
Sodium chromoglycate we never use at all.
You know it is out of
it takes 2 months to have its effect. It will work only in 20% of the patients that you use, and you have to wait for 2 months to know whether it's working or not, and you have to use it 4 times a day minimum to have the effect.
You know,
so who will wait?
Is it available? Drugs available in the market now?
Sodium chromoglycate?
No, not that sodium. SLIT for the sublingual.
Should be available. Yes, it is.
The drugs available in the market
there are
now?
2-3 companies now which are manufacturing SLIT.
No, it is available in the market.
Yes, in India. Yes. What is the cost? Generally, I think it's about 500 rupees a month.
Sir, what is your comment? A lot of these patients are taking montelukast in combination along with the inhaled steroids for treatment of asthma and allergic rhinitis.
Yes.
How exactly do they work, and how long do you continue? Is it worthwhile giving them, or only inhaled steroid or nasal spray does the job?
Montelukast and levocetirizine is never the first choice, except in the so-called intermittent rhinitis that we talked about. If you think that is persistent, if the symptoms are lasting for more than 4 weeks in a year, then you have to go for nasal corticoids. Now there are patients who, even though they are on nasal corticoids, are still symptomatic. They would need an additional help. There is something called as a flat dose response curve, that even if you increase the dose of nasal steroids or the steroids for their asthma, for example, after a certain point, which varies from person to person, they will reach a flat dose, which means the dose, the kind of response he achieved at 400 microgram is the same even if you give him 1600 microgram. This is called as a flat dose response curve. This is when additional drugs like a LABA or a Montelukast can help this patient.
How long can you continue them? Some of the patients are taking for years together, months together, and years together.
They have to use it as long as they need it.
Safety?
Safety is quite safe. They can use it for, I think you have that on ICS for about 30 years, no problem.
But they are using in bronchial asthma also nowadays, and they get good relief also.
Yes.
Sir, I wanted to ask another question.
Yeah.
So this allergic rhinitis is more a problem of the younger population, and asthma is the problem in the little elderly age group after about 35-40 years of age. And no doubt there are many younger asthmatics also.
Yes.
But it so happens quite a good number of them, they develop asthma.
Yes.
Some of them they don't develop asthma. And is there something like the disease going to die out after a particular age, this allergic rhinitis? Say after the age of 25-30 years, there are not many allergic rhinitis patients. Does it die out on its own in the natural course?
It is more actually, see, what you are saying is part of the allergy march, that the disease gets more progressive. But if you talk to your asthma patients, you will find that 80% do have rhinitis. It's not that it dies out, it's that it's less important because their asthma symptoms take over. It's just that.
And this aggressive treatment of allergic rhinitis, is it any insurance against prevention of asthma?
These two studies that I showed you, about 60% they can prevent asthma. So that's extremely good.
Well, I have a small question to you, sir.
Yeah, please.
Have you seen any cases of Churg-Strauss vasculitis?
Yes.
Masquerading as chronic asthma and eosinophilia in your practice?
There was, very few, maybe out of 20,000, maybe one or two, very few actually. There were some reports that Montelukast can cause Churg-Strauss syndrome in some of the reports which came when Montelukast was first introduced, and when patients were on oral steroids. It's actually not related to Montelukast because there has been no report afterwards. It's because these patients were thought to have asthma, were needing oral steroids,
yes.
And then that was withdrawn and Montelukast started, which just sort of unmasked the Churg-Strauss syndrome. It is not due to the Montelukast. How many times to be used depends on the severity. GINA 1, 2, 3, 4, GINA 2 to 4 would need an ICS, and this diagnosis most of the time is based on your simple clinical history. Like for example, we did a study that looked at you have daytime symptoms, nighttime symptoms, peak flow variations, as well as your spirometry. These are the 4 components that are used to diagnose severity in the GINA guidelines, which is the world guidelines. Or you need to use it as long as the patient needs it. Allergens are in the air, patient can't stop breathing, he has to continue. So as long as he breathes, he is exposed to the allergen. So you need to use it as long as they need it. To decrease the dose or to halt it, that's why you are using all the other measures.
Can we conclude the discussion here? And thank you, Dr. Mahesh, very much.